Okay, so first, a quick word about health system resilience. What do we mean? I'm going to paraphrase here the WHO, who recently, I think around 2022, came out with a definition. A resilient health system is one that can mitigate, prepare for, respond to, and recover from disruptive events with public health implications, while maintaining the provision of essential functions and services, and very importantly, using those experiences to adapt and transform the system for improvement. So anyone who wants to see more on that, you can see the WHO Health Systems Resilience Toolkit that, as I said, was published in 2022. And you've probably noticed this concept of health system resilience gaining more attention. And I think we can all recognize that this is in part because of the COVID-19 pandemic, which essentially brought a lot of health systems in northern countries or high-income countries to a standstill. Just next slide there, Jenny. There we go. It essentially brought health systems to a standstill. And so this whole idea that having a strong health system isn't quite enough, but you also have to have a resilient health system is important, or has become increasingly important for the whole world, but it's always been relevant for fragile contexts where the health system is usually very under-resourced and the severity and the frequency of disruptive events is quite intense. Next slide, please. Okay, so a quick look into the very different contexts that we were operating in. So Concern's ERNE program covered 8 regions, also known as states and provinces, depending on which country you're in, 22 health districts, and 273 health facilities. In Niger, we covered 6 health districts in Tawa and Maradi region, covering 104 health facilities, and an additional 31 health facilities covered by our ERNE partner in Niger, COPI, and ACF. The GAM prevalence ranged between 9 and 12% according to our most recent SMART surveys in October 2022 in 3 of our health districts. And in fact, in the ERNE program, we have implemented, or we have carried out together with the Ministry of Health, 18 SMART surveys. In DRC, we covered 1 health zone in Tanganyika province, covering 18 health facilities, and the GAM prevalence there was around 6% from the latest SMART survey. And in Sudan, we covered 8 localities in West and South Kordofan, supporting 15 health facilities, and the GAM prevalence ranged from 11 to 19%. And this GAM prevalence is based on weight for height Z score across all the countries. And in South Sudan, just south of the border from our Sudan program, we covered we worked in 2 counties in Unity State, covering 3 health facilities, one of which unfortunately was completely washed away during the floods in 2022. And we also supported 3 nutrition outreach sites from those health facilities. The GAM prevalence for our area in South Sudan is still pending as we finalize the report from the first SMART survey that we've been able to conduct since the lifting of COVID-19 restrictions and gaining more access post-floods. And finally, we have Ethiopia, where we have been covering 5 woredas spread across the Amhara region in the highlands and the Somali region in the pastoral lowlands. And that is our biggest coverage at 133 health facilities, and the GAM prevalence there has ranged from 9% in Amhara to 24% in the Somali region. So I think, as Aoife was saying, there are a lot of similarities. All of these contexts are fragile, but in their own way. They vary considerably around their ecological and livelihood zones. So Niger and Sudan fall in the Sahel and have similar long dry seasons, 1 harvest. But we also have in DRC and South Sudan a humid tropical climate with kind of year-round precipitation, but other issues and challenges to growing and accessing food. And then in Ethiopia, as I mentioned, we have quite extreme differences even within the regions. between Amhara and Somali. This, of course, the terrain, of course, affects our access and the health system and the health structure is much different and at different levels of strength and government leadership. The health service reach and capacity in these 5 countries is quite different. If we take Niger, for example, it's a very strong health system with good government leadership, and in DRC, due to distance and terrain, it's a bit more fractured. The levels of conflict, as Aoife already mentioned, we saw active conflict in Tigray, which affected our program in Amhara, and we all know the current situation in Sudan. The impact of COVID-19 and the restrictions differed by country, and finally, the disease profile. Next slide, please, Gillian, and my apologies to the translators if I'm speaking too quickly. Okay, so now a bit of a deeper dive on some of our health and nutrition results. So you'll see there in the top left corner, some of the information that Aoife had shared. So looking at Pillar 1, life-saving responses, Aoife had shared those figures, which are in aggregate, some of our health and nutrition results. And you can see on this screen a bit of a breakdown of our results for the management of acute malnutrition by country. So on the right-hand side of the screen, you can see the total children with severe acute malnutrition and moderate acute malnutrition that were admitted and supported with treatment services. And at the bottom, you can see Ethiopia had the largest caseload with more than 70,000 children with moderate acute malnutrition admitted and more than 10,000 with severe acute malnutrition admitted and supported for treatment. Niger had our largest caseload of SAM cases. We didn't support moderate acute malnutrition treatment in Niger because it was well looked after by the Ministry of Health with support from WFP. And you can see DRC, Sudan, South Sudan, the caseload ranged from about 5,000 to 18,000. Recovery rates were high and above the sphere target in all 5 countries. And the coverage using squeak surveys, we conducted 7 squeak surveys in the program areas. We have reached the sphere target in 3 of the countries, Niger, Sudan, and DRC, the sphere target being 50% of children with severe acute malnutrition being enrolled in the program. And in Ethiopia and Janamora, Warada, we found 38%, due mostly to access issues made worse by the conflict and the displacement. And also noted in the squeak report were stockouts of our ETF. So and then South Sudan, we're also awaiting the final results. The type of health facility support that we provided to the 304 health facilities included WASH rehabilitation, training, both formal and on the job, supportive supervision with the Ministry of Health, logistic and technical support, top-up incentives for health staff in some countries, particularly Sudan, South Sudan, and DRC, and medical supply procurement, and support for COVID-19 prevention and control. Next slide, please. Moving on to Pillar 2, preparedness and local capacity to respond, and breaking down the first part of that, which is around health facility capacity. Starting on the left-hand side of the screen, we developed a health facility assessment tool for the ERNE program. It assesses 14 health service domains. It's based on the WHO Service Availability and Readiness Assessment Tool, which has now been replaced by the WHO Harmonized Health Facility Assessment Tool. We added a nutrition module because we found it lacking, and we aligned indicators with the Joint Monitoring Program for WASH and Health Facilities, which is used across UN agencies and ministries of health. And finally, we created a scoring scheme to monitor capacity of individual facilities, which was also missing from, wasn't possible with the original tool. So baselines were conducted in more than 188 facilities. Results were used to prioritize support and tailor plans by facility. And end lines were conducted just in the last few months in 2023 and showed 4 of 5 country programs improved the average capacity score for their target health facilities. And you can see the average score for each country program This is the average score across those 14 health service domains, which I will show you in a moment. You can see, unfortunately, that Ethiopia maintained the same score despite many challenges, conflict, drought, etc., remaining at around 28%. Niger increased from an average score of 36% to 56%. South Sudan from 21 to 28%, Sudan from 28 to 39%, and DRC nearly doubled, or did double its score. And this meant that 72% of facilities increased their capacity overall. Next slide, please. Taking a breath for the translators. So just to show you very briefly, I don't expect you to see any of the figures on the right side of the screen, but those are our baseline and endline results. And I just wanted to show you the 14 health facility assessment domains that we used. And underlying each of these domains are subdomains that reflect different aspects of that part of the health service and the number of questions that are observed or asked at health facilities or asked of health workers. So there are 4 key results to note. The first is that the 5 WASH modules consistently scored the lowest at baseline and endline across the 5 countries. Water infrastructure did okay, and they all did improve. Generally, on average, they did improve, but sanitation infrastructure, hygiene infrastructure, environmental cleaning, and standard precautions remained a big gap. Child health service capacity improved in all 5 countries. Child immunization services improved in all countries except for South Sudan. And nutrition service capacity improved in 4 of the 5 countries and remained steady in Ethiopia. The tool was not perfect and it was a bit heavy to get going, but we have found this data invaluable to really support the ERNE program, and we have refined the tool now and we are using it in several of our longer term health programs. Next slide, please. Sticking with pillar 2, preparedness and local capacity to respond. And the second half of this pillar was really around the surge approach, as Aoife mentioned. And those who aren't familiar with it, it's an 8-step process to help health facility teams better manage seasonal peaks in caseloads of child wasting and child illness, with their often fluctuating capacity within health facilities. So one of our aims was to scale up the original CMAM surge approach, and we did so, supporting it in 173 health facilities in Niger, 91 in Ethiopia, and 11 supported in Sudan, with a special focus on 5 facilities, and then 1 pilot in South Sudan. And we knew going into ERNE that the CMAM surge approach had relevance not just for managing acute malnutrition, but also other seasonal child illnesses such as malaria and diarrhea. So we initiated a health surge pilot in Niger and Ethiopia and coordinated that with a similar pilot in Kenya under different funding, and we conducted participatory reviews. We documented much of this learning, and you can find some of it on the website, the Surge Learning Hub, which was created under ERNE. We initiated a global technical working group to guide some of this learning, and we conducted webinars, many field visits, and country reviews. And the outcome of all that has been a more holistic surge approach to manage peaks in child illness, including wasting. And we invite you to join the launch of their revised surge approach guide tomorrow on May 24th at 2 p.m. UK time, which will be led by my colleagues Lucy and Mariama. And Lucy has just put into the chat the registration in case you are a latecomer to that. There's still time. Next slide, please. So the last and final pillar is around prevention of malnutrition. And the bulk of this was or kind of the meat of this result was on the 16,000 women who participated in mother-to-mother support groups. Mother-to-mother support groups are peer groups where a curriculum focused on nutrition and health behaviors, child feeding, child care, and care of women themselves is promoted. It's a place to exchange ideas and gain support. And that's a picture of there of one of the mother support group leaders in Salahad Warada and Somali region and one of the participants. And we also launched father support groups. So more than 2,700 men joined in father support groups. And those groups, both groups had a gender module as well, and they were often the partners of the women who were in the mother support groups. So we don't have a lot of evidence from the ERNE program of improved behaviors, unfortunately, but I wanted to share some striking improvements in knowledge around these behaviors that we saw from Ethiopia. So in that graph, you can see breastfeeding knowledge. And there are 6 questions around breastfeeding, and about 1,000 mother-to-mother support groups across the ERNE waradas were asked these questions at enrollment. So that's the dark bar shows the percent of participants who answered the question correctly about breastfeeding, and the lower bar shows the percent who answered it correctly upon graduation about a year later from the mother-to-mother support groups. And you can see that it nearly doubled in a number of instances, and we found the same with complementary feeding and some of the hygiene behaviors. So it's one step along the pathway to improving behaviors, but we think it's good progress. Gillian, next slide, please. Okay, so on to the challenges. What we've learned tackling 5 challenges to health and nutrition service delivery. And you'll see the 3 first challenges framed in yellow are the ones that we're going to discuss in the breakout sessions. So the first, this is how we've boiled it down. There could be additional ones, but we're looking forward to discussing them more with you shortly. So the first challenge is around ensuring access to essential health and nutrition services. The second is ensuring availability of nutrition and medical supplies. The third is integrating nutrition into routine health services. The fourth is strengthening the health workforce. And the fifth is ensuring basic wash services in health facilities, which we found to be an enormous gap. And I think we're ready to move to the next slide. Again, thinking of the poor interpreters. So learning on challenge 1, ensuring access to health and nutrition services, we have 2 points of learning. The first is that mobile health and nutrition services are critical during mass displacement, such as we saw in South Sudan. And I've stolen that photo there on the right from my colleague Asatu, who will share more on the flooding in South Sudan shortly in the breakout rooms. And mobile health services are also essential when health facilities are damaged during conflict, such as we saw in our program area in Ethiopia. But you must have a clear scale down strategy. And again, we would invite your thoughts on what such a scale down strategy may look like and how we can take them forward. The second point of learning is that understanding seasonal caseload peaks and pressures on health services can help health workers better prepare to deliver continuous services throughout the year. And the surge approach can help do this. And we found this in Niger and Ethiopia, and more recently in Sudan. And that picture there are caseloads of or admissions of severe acute malnutrition cases plotted by month. And you can see the very sharp peak in July in an Ahud hospital in West Kordofan, Sudan. Next slide, please. Learning on challenge 2 around integrating nutrition into routine health services. We've been talking about this and working on it for years, all of us, including ministries of health, of course. But we find that we're just not there yet. The first point of learning is that funding streams and supply chains for health and nutrition remain quite parallel in many fragile contexts, particularly in South Sudan. We need greater alignment of activities, funding, timelines, and partners. And we really applaud ECHO and BHA and some other donors that have made a very explicit expectation of their implementing partners to support an integrated health and nutrition package. But we're finding that not all donors are aligned, particularly over the medium and long term. The second point of learning is that developing a simple integration plan at health facility level can bring change from the bottom up. particularly in South Sudan, and you'll hear more about this in the breakout room from my colleague Asatu. And the third point of learning is that health workers have reported the shift from CMAM surge, looking only at acute malnutrition, to the broader surge approach, looking at acute malnutrition and illness, is contributing to more integrated work planning across health and nutrition services. And that was found in Niger and Ethiopia. And the image there, if you can see it, is a page from the Ethiopia Ministry of Health's protocol for the integrated management of newborn and childhood illness, which is the core health protocol in most countries. And you can see on this page that it includes an assessment of acute malnutrition. And in further pages, the treatment of acute malnutrition is well integrated into the protocol. And the Ministry of Health in Ethiopia, in fact, has a national plan to integrate nutrition services into the health system. Next slide, please. Learning on challenge 3, ensuring availability of nutrition and medical supplies. The top point of learning is that nutrition and medical supply chains must be strengthened at all levels. And we saw significant pipeline breaks in nutrition supplies, as well as medical supplies throughout the ERNE program. And then focusing on last mile delivery of nutrition supplies. The first point is that Ministry of Health teams are increasingly responsible for RUTF delivery to health facilities, but they're often overstretched. So partner NGOs could and can better support the Ministry of Health if their role is made clearer vis-a-vis Ministry of Health, UNICEF, and other actors. The second point of learning is that we really must invest in a more standardized real-time system to monitor RUTF and RUSF stock in health facilities if we're going to improve forecasting and timely delivery. It remains extremely fractured and everyone seems to be doing a little bit their own thing, and the information often comes far too late. The fourth point of learning is that we need innovative solutions to transport supplies and staff. This is nothing new, but vehicles and fuel remain a huge barrier for Ministry of Health teams. Next slide, please. Got 3 more slides. Learning on challenge 4, strengthening the health workforce. National governments must recruit and pay health workers a living wage. Sorry, I should say living wage. We've just found that there's an ongoing health worker crisis wherever we work. They are rarely paid or infrequently paid, and inflation is really making their take-home salary barely something they can live on. And we would encourage donors as well to support governments to find solutions to address this ongoing health worker crisis. The second point of learning is where NGOs and UN agencies must pay top-up incentives to frontline health workers in crises to keep them at the facilities and able to work. The rates must be harmonized and respected across Ministry of Health and partners and regularly adjusted for inflation. And next slide, please. And the fifth challenge is around strengthening WASH in health facilities. Sufficient resources must be allocated for WASH in health facilities. The needs are huge, and the centrality of water and sanitation to deliver safe and effective health services, it can't be overstated. So where budgets are tight, unfortunately, be ready to prioritize in order to provide a complete package to health facilities. And in the words of my colleague, Frank Flaschenberg, our senior WASH advisor, don't sprinkle your WASH resources thinly across too many health facilities. In the middle, you can see the average cost, how we had to prioritize. These are just examples from Ethiopia and Niger, which facilities we supported for WASH infrastructure and how much they cost. It's not cheap. And the last point is around the WASH Fit approach, which is a UN and Ministry of Health approach to develop practical action plans to repair and maintain WASH infrastructure and services. We started to implement this towards the end of the ERNE program in a number of countries, and we will continue to do so. And on to the last slide, I hope I'm doing okay for time, is to launch us into the breakout sessions. So we have 1 hour and 20 minutes to discuss. We have 3 challenges. So in the first room, the group will be talking about ensuring access to services during displacement or conflict and the role of mobile health teams. with presentations from our South Sudan team and our Ethiopia team. In the second room, we'll talk about integrating SAM treatment into routine health service delivery with another presentation from South Sudan, as well as one from Niger. And then in room 3, ensuring nutrition supplies, we'll hear experience from Sudan and Ethiopia. And the objective of the breakout sessions is to agree 1 to 2 recommendations to address each of the challenges and key considerations to take that recommendation forward. And then we'll come back to plenary, and each group will have 5 minutes to present. And you have been assigned, so there will be a button pushed very soon. You have been assigned, to the best of our guess about your background and which one you may be interested in. So you will soon be assigned to one of these groups, and your facilitators will provide more instructions once you arrive in those breakout rooms.